Thank you. That was a very generous introduction. So my name's Nick, and I guess I've been working in the field of integrated care for maybe 25 years. And I think for a lot of us in this room, we all have either lived experience as family member, as a carer, or indeed personally, around the fragmentations that exist in being able to live the lives you want to lead because of the fragmentations that we see in the way that care is organized and delivered around your needs. So you said visionary, that's probably quite strong. I think that the point that I would like to make before starting is that ultimately integrated care is about hands-on care. It's not a highly technical approach that requires governance and accountability or information systems or financial models. The transformational effect of how we support people to live well with conditions that they have, whether they be physical or mental, is very much around how health professionals, social workers, and others work together with and around people and their family members and the community in order to draw together all of those assets to keep people healthy and well. And there are enough case studies and approaches around the world to tell you what a significant difference that can make to people's lives, to those who are working within the sector, and indeed benefits to the health and care system as well. So what I want to do in this presentation is say a little bit about that journey, focusing in on some models of care that seek to support people with moderate to severe mental illnesses, but also looking at them as if they're people, because if people have these illnesses, they're also presenting with many other things that they're dealing with in their lives simultaneously. So I'd like to acknowledge that I'm coming from the Central Coast Research Institute, which is the land of the dark and young people. So I'd like to acknowledge the traditional custodians of that land and pay my respects to elders past and present. And I might just start with some first principles. I think I might have just described it. What is integrated care? Why has this been, I think, part of my life for quite a long time? And I suppose in my career now, I started off as a social scientist. I still am a social scientist, I suppose, which basically means you look at relationships and you look at how things work and you try to understand why behaviors are the way they are or why systems don't change in the way. You look at all of these different things. And integrated care was fascinating for me because it's a very sort of complex service innovation. It has many different moving parts to try to understand how we bring care and services together more effectively around people. And then I realized as I moved into focusing in on healthcare, particularly older people, really just how unfair, going from an academic, just how unfair the system is, how poorly served people are by the way that we deliver care. And then eventually it became my job to try to be an advocate for change in this area. But to put it simply, integrated care is necessary when those fragmentations in care mean that it's become so poorly coordinated around your needs that there is an adverse or suboptimal impact on your experiences and care outcomes. Or in other words, integrated care therefore seeks to improve the quality and cost effectiveness of care by ensuring that care services are well coordinated around their needs and is by definition therefore holistic, people-centered and population-oriented. The person's perspective becomes the guiding principle around how we should be delivering our care services. This is a long list, but if I was to ask you, what are the issues that you're facing? If you were to draw for yourself or for the people who you care for or the people who you are treating and supporting, their web of care, the sorts of things that might keep them healthy and well, it won't just be services from psychiatry. It'll be a whole range of different things related to the physical and other forms of the environment that sit around them. And the key problem with fragmented care is that all of the different players that could be involved in keeping that person or that family healthy and well are all working separately. And there is a lack of ownership between all of those different players to the overall issues that you might be facing. And you might say, well, okay, well, maybe we can give more agency, we can give more empowerment to people themselves so that they become more involved and invested in their own care. This has become very popular as a way of providing people with financial incentives to purchase care on their own behalf or design their own care packages and so on. But the problem with that is, A, it's not done very well, and B, it's a very paternalistic way of doing things. So instead of trying to move towards shared decision-making and having equal conversations and seeing people as partners of care, it's kind of a very paternalistic system of we know best and you're going to get a care package that we've previously designed. And of course, also for many people, they don't have that agency and they do need that support to engage in the care services around them. Other problems are that there's definitely poor communication often between professionals. How many of you here with lived experience or caring for your loved ones have to repeat your story again and again and again to the same sorts of services in order to get what you need? Care and treatment is often, and this is a key thing I think I want to stress today, care and treatment only tends to be for your presenting disease. So if you come out of hospital and you're the diabetic patient, you become the diabetic patient, despite the fact you might have a whole range of other things going on. And the same would be true for mental health, and the same might be true for disability. And that is an issue. So you end up in most of our systems with this simultaneous duplication in care, when many of your different health professionals and care providers are doing much the same thing, but in different silos. But also the gaps in care where we fall through those gaps and we don't get the coordinated support that we need. And this means that people have, it's a poorer and more disabling experience of care for people. It reduces ability for people to live and manage in the way their needs effectively. And it also leads to poor systems outcomes. It's more expensive. There are more hospitalizations. There are more use of medications that could be managed more effectively. So these are some of the key problems. And when you look into the evidence around individuals living with psychosis, particularly adults with psychosis, they live on average with at least, or on average, can't be on average and at least, on average 7.4 other presenting conditions, many of them chronic conditions. And that's a really important statistic, because if you just looked at an older person without psychosis, you would have to be about 80 years old before you had 7 concurrent conditions that you're living with. So when you start to think of a person with psychosis, on average, they're already at the point where their care needs are very complex, and the situation that they are living with is pretty fragile, not just because of the psychosis themselves, but all of these other things that they're having to deal with as they go through that journey. So the problem with our systems, I think, is, and this is true of probably of psychosis and mental health, but it's true of any other person presenting with one specific disease, is that physical issues and comorbidities are often overlooked in how we support people. Complex treatment challenges are not addressed. Diagnosis and supported access to care is often inadequate. Pharmacotherapeutical treatments are often limited to resolving the symptoms, and they may have unintended side effects given all of the other things that people are living with. And in many cases, there are issues with stigma, social isolation, leading to difficulties for people to engage in things like their preventative attitudes to food. And this burden of severe mental health issues is the largest cause of disability in all health systems around the world. And the cost of this, let's just focus on the cost of this for a second, is really very significant. So these two graphs, don't have to worry about reading it, you just have to see the graphs are going up. So the graph on the left focuses in on the increase in costs related to specific diseases, and then diseases if they have also comorbid mental health issues. So if you have mental health and cancer, it's at least twice as expensive for the system to support someone in that space. And how many people with cancer don't have a mental health issue? It's a very strong association, as it would be for diabetes and other issues. And the graph on the right, remember I'm saying that individuals with psychosis have on average 7.4 concurrent conditions. The graph on the right tells us that the more conditions that people are living with, the more likely it is that they're going to be more expensive to the system if they have mental health. So if you have 6 chronic conditions, the last graph on the right, if you don't have mental health issue, your cost is in the blue bar. But if you do have a mental health issue, the average cost is at least 2.5 times more. So in other words, we haven't even reached the point in that graph where the average person with psychosis sits. So if I was a system thinker looking at these graphs, I'd say there's got to be something to do here in terms of working through how we deal with individuals with psychosis or other severe mental health issues, and how do we support those complex comorbidities that they live with and not just the presenting conditions. So this leads to 4 key reasons for integration for people with psychosis. It is because they have high levels of comorbidity between both physical and mental health conditions. They have limited support for wider psychological aspects of physical health and illness. There are persistent inequalities, and Australia is particularly unequal in the way that it supports people. In life expectancy, and there's poor management and high prevalence of medically explained symptoms. So I mentioned that people with psychosis living with 7.4 conditions. People with psychosis also die on average 20 years. If you're a man, life expectancy is 20 years less. That's 16 if you're a woman, 17. This is telling you something about how we support more generally. So integrated care's hypothesis is we can somehow, by changing the way that we support people, find a way to achieve 4 things. One is to improve the user's care experience and that of their families and their carers, to improve the physical health and mental health of those individuals by supporting people to get into remission or to manage their conditions more effectively. We can improve the cost effectiveness of the system. And for those supporting people with mental illness, we can improve the work-life balance. I won't go through this slide. I'm sure you'll get the slides afterwards, but the evidence basically suggests that if we focus in on the relationship between our health professionals and others in that ecosystem of care that people need, in a relationship with the person and their carers, potentially in the home environment or in the community, then there is every chance and every evidence to tell you that this is going to achieve those objectives. So let's have a look at 3 innovations. And we'll start, we've got 4 slides here. We'll start with the first hypothesis, which was how do we move, I think, the way we deliver this services from more sort of individualized medical care, you might call it that, to team-based or holistic or coordinated care. So the diagram on the left represents screening for early emerging mental experiences. And the idea is if you do your screening and you need to have, and you see people who have significant complex comorbidities, you work them through into an integrated mental health visits, and otherwise you take them to more sort of care as normal in order to get their entry into care. This, I think, is reasonable. However, it's not fundamentally changing the way that we're supporting people in the way that they would want to be supported. It's just a care pathway methodology to support people to get more treatment. The diagram on the right begins to tell you what is it like to live with psychosis? What is it that we need to do to support it? So if you have the client in the center, person in the center, and you start to work around that, well, the services that you would require are all the sorts of things that would be in that integrated mental health visit option on the bottom left there. So you would have, we'll read the slides, you would have all of these. So you'd have psychotherapy, you would have education support, you would have case management, you'd have medication, all of the sorts of things you would need for the care and treatment of the presenting disease. But we know that for the person to live more effectively, you need all of these other things around them that's going to make it helpful. So how am I going to improve my independence? What about the emotional therapy? How about the environment in which I'm living in, or the physical and nutritional aspects of how I live? What about my engagement with the community? How do I get back to work? How do I feel as though I've got some agency and some worth for myself. And all of these things can be supported through other forms of care and engagement as part of these sorts of packages. So I'll give you 3 stories. So the first one's Stay Strong, or Kia Kaha from New Zealand. Not directly for psychosis, but certainly for people living with mental health. This was launched in 2013, looking at comorbid medical and severe mental health issues. And the key approach is, how do we provide empowerment and supported self-care to the clients and their families? But it's about access to team-based psychology in routine healthcare. So in other words, this is not a hospital-based specialist service. This is routinely available in primary community care settings in and around where people live and work. And these team-based services have care meetings, and they work in a relational way with patients and families to be able to support them. So you see in this system, the outcomes for the Maori community in Counties Manukau, which is just south of Auckland, significant reductions in hospital admissions, reduced psychological distress, improved patient activation in how they're able to take control of their own lives, and it's become embedded in routine care. So the diagram on the right gives you some of the stories that people are saying in terms of the improvements that they're facing. The one I like the most here is that the wife, who was significantly distressed, is now no longer distressed. The individual with the mental health problem feels more in control. The daughter doesn't see her dad angry and distressed all of the time, and so on. And it's really a very simple intervention, because you're looking at a team-based approach that focuses in on the environment in which people are living, not just on the treatment. Here's another example from a colleague who's actually on the advisory committee, international advisory committee of our institute, Dr. Brenda Rees-Brennan. And all of these have, actually this one doesn't, but most of them have links to the places where you can go to read more. Now, Intermountain in the USA is a health system based in around Utah, big health system. And over 20 years, they've been focusing on how do we normalize mental health care within a primary care environment. And they use a step care model. We were talking about that earlier, just over coffee, from people who are presenting because they have anxiety or rumination or issues related to mental health. And then as you move through the step care approach, you begin to ramp up the care and services required as people get to the more severe end of the spectrum. But they do this through a single team-based care model, which involves psychiatrists and psychologists and nurses and social workers and potentially GPs as well. And they have named care coordinators who are allocated to provide relational continuity, one-on-one continuity, including giving you the care of their phone number to be able to support people over time who come into the system. And there is a lot of staff training about how you understand people living with mental health and how you support them effectively, and the cultural awareness that is required in order to be able to manage that effectively. So simply by creating an approach where you create multidisciplinary teams that focus on psychiatric care, yes, but also social work and welfare and supporting all of your other conditions, you're creating a team-based environment in the community where people are living. You're seeing this 54% reduction in ED admissions, 47% lower per patient medical costs, and a 5-fold return on your investment. Do one more. This one you will not have read because all of the information is in German. However, the Hamburg model in Germany is a good one, because since 2007, and there have been 3 major evaluations of this project. This model of care, the Hamburg model, focuses on severely ill patients with psychotic disorders. And their approach that they've developed over time is what they call a therapeutic assertive community treatment. Not sure if that's something heard here. Maybe I'm already talking to people who know about this approach, but it's very similar. And it's actually quite similar to the way you would care for older people with complex needs in a community anyway. There are other models that look very similar to this, that are focusing on people with general conditions and not just psychotic disorders. However, it's based around relatively, how do you, humble sort of day clinics that are accessible to people in their local communities, which people can access. They might be in a shopping center or in a place that is friendly and open to them, so they don't feel the stigma of having to go, and they feel that it's a welcoming environment, as well as inpatient and outpatient clinics driven by the professionals from the hospital. But the point is, it's the team. So they have a care team, and they also have, for people when they fall into crisis, a specialist 24/7 response. And this multidisciplinary care team includes social workers, nurses, psychiatrists, psychologists, recovery, they call them recovery companions, primarily trained up volunteers, and assisted living support. My understanding is around 70% of that team are psychiatrists. However, it's quite a big team that they've developed in Hamburg. And from these 3 large evaluation studies in Germany, you see lasting improvements in symptom control of people living with psychosis, improved quality of life, more people getting back to work, and more people getting involved in social participation. So in other words, people living with psychosis are feeling more able to live the lives that they might want to lead. You see reduced relapses, reduced hospitalizations, higher outpatient contacts, and more group-based psychotherapy. So being able to create a kind of a peer approach where people are able to talk to each other about their conditions in an environment that is culturally safe, as you would say in Australia. Particularly for the younger adults, you see quite a high remission rate of people who are able to control their symptoms and then carry on in their daily lives after this care in a relatively normal way, and it's lower cost to the system. So this isn't rocket science. This is team-based working in primary community care, where you bring together the best of psychiatry with psychology, with care support, with welfare, with social workers, with volunteers, in order to provide a nurturing environment for people to live well with their conditions. It's not visionary. It seems to me to be pretty simple in terms of what you would want to do to achieve it. However, integrated care somehow has become a dirty word, it's become a difficult phrase. You know, it's a bit like when if you go to the supermarket and you go to the fresh food aisle, because if you go to the old food aisle, well, that stuff's rubbish. So care is one thing, but integrated care is clearly better. So it's begins to lose its meaning a little bit. Yet when you look at policy in Australia, and we'll come on to a policy slide in a minute, almost every state and territory has some form of integrated care thinking, including for mental health, within their plans. Yet a lot of the programs that we've just described, we've described 3 that have been quite long lasting. The majority of the programs that you see in this space, including in the area of mental health, are very fragile. They start with pilot funding. There are politics involved, so you don't have the leadership over time to sustain these new innovations. The finances come from time-limited grant money, or the incentives in the system mean that what you're trying to achieve is kind of the orange lozenge on the side of an organogram. It's not really part of the system, and it's there as somebody's special project. Nobody really loves it that much except the people within it, and it's very easy to let it go in times of crisis. There's often a lot of professional tribalism that goes on. I was involved in research in Cumbria, which is a kind of an English rural community with lovely lakes up in the northwest of England. And they wanted to introduce a form of primary care mental health model, but the psychiatrists in the hospital wouldn't have it at all. And they had to work with psychologists and GPs to get a service up. But if you needed that specialist treatment, you had to go to the hospital. Social norms and values, evidence and belief. So all of these things make it difficult. And Australia is a case in point. So we did a policy analysis a year ago, and this is generally speaking that when you look at the way Australia has begun to address some of these complex problems, including in mental health, I'm going to call it disjointed incrementalism. In other words, we're muddling through. We see a problem, we'll throw $2 billion at it, the problem will go away. And it's the equivalent of putting a patch on a broken Windows system. We're just going to put another patch and another patch and another patch without fundamentally changing the system. And the Australian system looks a little bit like this. It's a platypus. People seem to like it, but it seems to be a whole range of different parts that have kind of been worked together and called a system. And the platypus is amazing, really. It's bioluminescent, and it's the only mammal, I think, that lays eggs, and I think it's it's also venomous. It's an amazing creature. Only in Australia would you invent something like this, I think. But anyway, when you look at the direction of travel, are we moving to integrated care? Are we moving in a direction of travel that is likely to lead us to a better future for people living with psychosis? And I think we have long-standing system fragmentations, federal v. state, public-private, all of these sorts of elements. We're beginning to see enhanced roles for GPs, enhanced role for primary care, but I'm not really sure we're dealing with mental health or psychosis or dementia or all of the sorts of issues effectively enough within the communities in which people live. Primary health networks may have a role to play, but they're pretty fledgling organizations and their impact is limited, I think, at the moment. So you're left with some special projects, despite the fact that all states and territories kind of want to move in that direction. So the question is our glass half full or half empty? So coming back to what our chair was talking about, talk about glacial progress. And I think that's possibly right, because when you look at an range of things that we need to do to support people better, the evidence is already there. And in fact, you don't need the evidence, because if you run what's going to happen to people without changing the system, it's pretty unsustainable. So you can already see the system's traveling in the wrong direction. So it's got to be doing something about it. Integrated care is one of your bets to be able to do that. But the issue is that progress is indeed glacial, but at least not geological. So what's the future? 2 more slides and then we'll finish off. So 5 key areas, I think, where we could make a difference. So psychosis, is this really included in public health and health promotion programs? How do we support prevention and public health more effectively? Could do that. Primary care, I think this is my key message. Multidisciplinary primary care with a range of different organizations and with the community and with people to improve the understanding and management and what it means to live with psychosis, to overcome that stigma. Care management, better care coordination of people for all of their needs and not just their presenting conditions. We can do a lot better in hospitals to address psychosis support and the agitation that people have in moving into these environments. Supporting effective care transitions. People with mental health issues, when they come out of hospital, feel as though they've fallen over a cliff. How do I reintegrate into the community, which I'm now back into? Happened to my dad. Oh, you're better now. You can come out of your mental health facility, come back into the community. Everything will be fine. It isn't. There's no support there to understand how you're going to live, how you're going to reintegrate with that social environment. And hence, community and social, big gap in support for people living at home, particularly for older people in residential aged care. So lots of different areas where you could do projects that might influence. I'm not saying pick all of this, that would be trying to eat an elephant, but there are different areas in which you would do it. And I think the key one is how we beef up primary care. So here are some of the emerging themes. You need to go beyond care pathways and treatment access to become more holistic, to redefine what the core business of our caring really means, to help to empower and activate consumers to the best of their capability, to reduce stigma, to harness those wider community resources, and really begin to communicate. Because if people start to communicate with each other more effectively around people's needs, regardless of whether the system is working together or not, this can lead to changes in your own individual behaviors that leads to a culture of learning, and a culture of learning that's more likely for people to be aware of and respond to the needs of people with psychosis living in the community. So, thank you.